Good evening, everyone. Welcome to our last webinar in the series on cirrhosis care, practical tips you can use in your practice. My name is Panita Tandon. I'm an associate professor of medicine and co-director of the Cirrhosis Care Clinic and a transplant hepatologist at the University of Alberta in Edmonton. I'm also one of the medical directors for the Office of Lifelong Learning and the Physician Learning Program. And the Office of Lifelong Learning is committed to providing the latest information, advice, and resources related to cirrhosis care for physicians and other healthcare providers. Just before we begin, I would like to acknowledge that we're on traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. So with that, I am really pleased to introduce Dr. Saifee Rashiq, who's going to share with us his tips on managing pain in cirrhosis. And Dr. Saifee Rashiq is a specialist in pain medicine and anesthesiology at the University of Alberta in Edmonton. For the 20 years up to 2018, he was director of the Multidisciplinary Pain Clinic at the University of Alberta Hospitals. His clinical interest is in medically and psychosocially complex patients and non-organic pain syndromes. And he wanted to let us know that he recently tried cannabis-infused chocolate for the first time and found it completely underwhelming. So with that, I'm going to turn it over to Dr. Rashiq, who can take us through pain in cirrhosis. Thanks, Saifee.
All right. Well, good evening, everyone. Thank you, Panita, for that fulsome introduction. And it's a real privilege to be part of this fantastic series on cirrhosis care. I mean, if like me, you're not a cirrhosis expert, you will assuredly have learned a lot. I know I have. And it's one of those diseases that it would seem sort of bubbles under the surface and affects many more people than we know. As Panita said, I'm a pain specialist. I'm an anesthesiologist. I'm from a non-cognitive specialty. But what I do is I sit in a pain clinic and I hear the stories of people who have pain from all kinds. And I should say at the outset that although I'm giving this talk within the framework of a cirrhosis webinar series, many of the points I'm making, in fact, most of them are general in the sense that they speak to this idea of chronic pain, of refractory pain, of difficult pain, and not necessarily just in the cirrhosis population, but in people with medically complex illnesses, and people with mysterious illnesses, and that kind of thing. So through that lens, let's embark on this journey that I've decided to call Fear, Fibrosis, and Frustration. And let's start by telling a story. Let's give this guy a name. Let's call him Bill. And you don't need to be any kind of rocket scientist to figure out that Bill is not happy. You know, not everything is happy in Bill's life. You may be a family doctor, you may be a hepatologist or a general gastroenterologist. And what you get from Bill depends on the context. But here's what's going on. He's got an injured liver of some kind, and he drinks a lot. He drinks a hell of a lot. And putatively, the drinking is the cause of his liver disease. He's got some ascites. And if you're in the liver business, all of this is sort of cogent and relevant. And you're excited by this. You're excited to deploy your skills, your learning on the liver to make his life better. But he doesn't care about that. All Bill cares about is his back pain. Every single time he comes to see you, at the first opportunity, he diverts the conversation to his back pain. It's been there for years. It's getting worse. I have it all the time. I can't do anything. When I go up the stairs, when I go down the stairs, when I pick something up, when I put something down, when I sit down, when I lie down, all I ever get is back pain. Back pain, back pain, back pain, back pain, back pain. The story just goes on and on and on. And after a while, you start to get this sort of dread of asking him how things are, because you know he's going to talk about back pain, and frankly, you're not interested in his back pain. Your mind is elsewhere. And if you are interested in his back pain, you've come to the conclusion that there's nothing much you can do. You've sent him for x-rays, you've sent him for MRIs, you sent him to your friendly neighborhood radiologist who, for a very reasonable fee, injected cortisone into some facet joint or somewhere. You've sent him to physio. You've tried various drugs. And then he says to you, you know, I went to the Emerge the other day, and a guy gave me a dose of something called and you get this horrible sinking feeling because you think, I'm about to be dragged onto this train of opiate prescribing, and I don't want to do that. I want this to stop. Now, if you've been in practice for any length of time, this story will be familiar to you. And my suspicion is that you don't look forward to looking after these people. You don't look forward to this aspect of their illness. And so I'm going to use what I believe is a model that will work better for you to try and at least break down the barriers and help you approach these patients in a way that is constructive. Now, I'm not promising any miracles. I'm not here to tell you that we cure these people. But what I am here to tell you is that by thinking about chronic pain in a different way, both you and the patient can come to a better way of resolving these conflicts, and you can stand a more meaningful chance of moving the patient forward. So here are my objectives for the next half hour, 40 minutes, as long as they give me. I'm going to talk about, on the top left, I'm going to talk about the pathophysiology of chronic pain and why it differs from the kind of pain that you get from a sprained ankle or from having a baby. In the middle, I'm going to talk about common approaches and why they commonly fail, and that'll become clear as I speak. I'm going to give you some tips for success. I'm going to talk about opiates because this is a very emotive issue and you need to know how to approach this in a sensible and rational way. And then we'll have some questions, and I'm delighted to hear that Dr. Brisebois is going to come on the panel, and we'll have an excellent chance to really address the questions that are bugging you. So like Dr. Tandon said, please be forthcoming with your questions. I won't have a chance to look at them during the talk, but we'll certainly address them afterwards. So if you didn't watch last week's webinar about palliative care and cirrhosis, you really should. And I've taken the liberty, without asking permission, I should add, sorry, Amanda, of borrowing this picture, which I think encapsulates brilliantly how our goals for a patient change as their life and their disease progresses. Now, I've added a bit on the far left over here. I've added an average person spraining their ankle and getting some pain from that, the so-called acute pain. I'm not going to talk about that. If you want, we can talk about doses of drugs and how you approach short-term self-limiting illnesses, but I think you're all experts at that. We all do that every day. If you're a family physician, this must be the bulk of your work. Broken fingers and endometriosis, stuff like that. I'm not going to talk about that, but we can. And I'm also not going to talk about people who are towards the end of life in their last days, weeks, months, hours, because you heard a brilliant exposition of that last week. And frankly, I'm the wrong guy to talk about it. My world is here. What I'm going to talk about are people who have debilitating, troublesome pain in the context of normal life expectancy or predictably normal life expectancy, for whom the solutions are just mysterious. So you all know this from medical school. You all know these pathways. On the top left of the picture, you'll see what happens at the cellular level when tissue injury occurs. Neurotransmitters are secreted. And then if you look at the figure on the right-hand side of my slide, you'll see there are special pathways that transmit that signal, firstly into the dorsal horn of the spinal cord, and then across to the other side. Anybody know why? No one's ever been able to answer that question. Why not just have it running up the same side? Anyway, I don't know. But then it goes up the spinal cord, through the thalamus, and up to the higher centers where that nociceptive input, having been modulated and amplified and changed, is then converted into the human experience that we call pain. Pain is in the brain. Bertrand Russell, the famous British philosopher physician, winced when the dentist was drilling his tooth. And the dentist said, well, where does it hurt? And he said, well, in my brain, of course. Good anecdote. Anyway, all of this is by the by. What you really need to remember, if you haven't been taught already, is that in parallel with this system, there is a whole apparatus of descending modulation of the pain signal. By descending, I don't just mean literally in that it goes from the top to the bottom, but I mean figuratively as well. Our previous experiences, our previous pain experiences, our experiences with anxiety, with fear, our culture, what we are allowed to do, things we are allowed to say, and ways in which we are allowed to behave are encoded up here on the top right. And those experiences are used by the nervous system to modify the signal. They act here in the thalamus, they act here in other places, and they act here on the dorsal horn of the spinal cord. So we are equipped with a system that can both amplify and reduce pain innately. I'm not just talking about endorphins. I'm talking about neuromodulation of the pain signal. So, for example, you'll have heard of Lamar's techniques for pain-free or drug-free obstetrics. Well, that's how this works. We all have ways of overriding the pain signal, and we all have ways of amplifying them. And that, I promise you, is as theoretical as I'm going to get. But you need to know that what I'm about to tell you about the wider context of pain is not something I just pulled out of thin air. It's based on neuroscience, and we can prove it. This is the biopsychosocial model of pain, promulgated by a fellow named Engel in 1977, and it encapsulates why people hurt. Not why laboratory rats respond in a certain way to a nociceptive stimulus, not why surgical patients flinch when the anesthetic isn't deep enough. This is the best explanatory model of why human beings suffer this thing called pain. And you'll notice that the three-legged stool of pain is propped up not just by things that go wrong in the body, but also by things that happen in the mind, your cognition, the way you think, the way you feel, and also by the environment that you're in. If you're a special forces soldier standing on parade, you respond differently to pain than a civilian, because you're simply not allowed. Your culture doesn't permit you to wince or to hesitate or to do any of those things. You must deny the existence of your pain, because that's what your environment tells you to do. This is the key to unlocking why people hurt. And it's very similar and less complicated, I would argue, than what Dr. Brisebois showed us last week, which essentially is a three-legged stool with a few more legs on it. The people at Pallium have included things like culture and spirituality, and you can make this as complicated as you want, and assuredly, whatever system you come up with will be an oversimplification. But the take-home message for the average Joe and Jane practicing medicine is that pain is a lot more complicated than just what's going wrong with your body. And I'll bet everything that you and I have ever done for that guy, Bob, was right here on the third leg. Diagnostic imaging, drugs, injections, rehab, it's all based on one leg of the stool. And if you take one thing from this lecture, it is that if you deal with a complex pain problem, by doing that, you will assuredly fail. And you may say to me, well, most of my patients don't need that. I mean, most of them just take the pills and get better. Why haven't they got things happening in their minds and their environment? Well, the answer is they have. But they're in a position where they can just cope with it better. So here's another way of thinking of this. If somebody has 9 out of 10 pain, you can think that some of it is biological. Some of it is due to a torn something or other. In the case of someone with a purely functional illness like fibromyalgia, this is zero. There is virtually nothing biological about that pain syndrome. And then some variant of it is psychological. Some component of it is psychological, and some component of it is environmental, social, cultural. This doesn't exist in real life, but this is a handy way of thinking about why pain problems behave the way they do. Some of it's biological, but only some of it. And if you only address that component, the solutions won't work. This is a diagram that I use when I'm teaching patients about this. And incidentally, education about pain and why people hurt is a very powerful therapeutic tool. And we use it remorselessly in people who come to our facility for our rehab programs. We teach them all this stuff. We show them diagrams of neuroscience. And part of that is to reinforce the fact that they're not just crazy. I say, look, there are pathways in the brain that modulate pain and other pathways that modulate fear. And I say, after a while, if you have enough pain and enough fear at the same time, you get this schmoz where the brain can't tell the difference between a stimulus that is painful and a stimulus that is just frightening. And that's why people react by saying, I hurt, when what's really happening is they mean I'm scared. So who are these people? Why do some people end up in my pain clinic with 10 years of back pain for no biologically plausible reason, and other people just sail through life trouble-free? Well, there's a whole bunch of reasons. And if you've been to any kind of CME lecture in the last 10 years, these are the same risk factors that make people cirrhotic, diabetic, obese, give them lung cancer. I mean, it's all the same. You know, the people who have these in any measure are a setup for my disease, chronic pain, and all the diseases that you treat every day of the week. Of these, anxiety is by far the most pernicious. If you could get rid of one thing in a chronic pain patient, then anxiety would be the thing that I would choose to go. And there is a theory, there's a model of chronic pain, which says really what it is a somatic manifestation of anxiety more than anything else. And I think there's something to be said for that. How do you tell if someone's got what I'm calling chronic pain versus what you might call real pain? Well, what if he's got a real lesion? I hear that all the time. That's the reason you send these people for tests. That's the reason that you worry that someone who complains of pain over and over again really may be harboring something dangerous. Well, here are some clues. These are generalizations, but they stand up pretty well. Somebody has pain that you can't explain and it's increasing over time, it's probably chronic pain. If it's spreading to other body parts, you know, if it begins as back pain and then it becomes shoulder pain, then it becomes neck pain, and it becomes elbow, that's probably a sign they've got chronic pain syndrome. If they have other functional illnesses, irritable bowel syndrome, fibromyalgia, interstitial cystitis, chronic fatigue syndrome, you pick your poison. These illnesses tend to congregate because they have the same explanatory mechanism. If they're highly disabled but not that impaired, I always think of chronic pain syndrome. If somebody has the physical ability to lift something but refuses to lift things repeatedly and progressively over time, then that's a sign that they have chronic pain syndrome. If you solve their pain problem by giving them an analgesic and they still remain disabled, persistently disabled, that's another bad sign. The dialogue you'll often have is, well, if I could just have a little bit of pain relief, by which someone's talking about a medication, well, then I could do everything. So here's your medication. Do you feel better? Yes, I do. Are you doing the things you want to do? Well, no, it's still, you know, I'm still quite ready for that. That's a sign of my illness. Polypharmacy, despite side effects, if someone insists on trialing and demanding different kinds of medications, even though they're not making any difference, even though the net effect is low, then that's a bad sign. And that indicates they've got chronic pain rather than a structural or a physiological pain syndrome. If they're deconditioned, if they have this thing we call kinesiophobia, if even the idea of movement is painful, if you say, well go ahead and squat down for me, oh, well, I'm not doing that. Kinesiophobia, to use a bit of pain clinic jargon, is a very sinister sign, and that's a sign they've got chronic pain syndrome. And then tender muscles. You know, a lot of people don't get examined until they come to the pain clinic. A lot of people with back pain don't get examined. What they do is they get imaged. And if they have tender muscles on either side of the lumbar spine, then they've got what we'd call myofascial pain syndrome. That's a disease that responds to exercise. And you should never send those people to a spine surgeon. So at the end of this, I think a good way of, now listen carefully, I think a good way of thinking about this is to imagine an imbalance between what the patient's burdens and the patient's resources. And some people's resources are better and some are others. And if they tip, they end up with chronic pain. Now, I hasten to add, never ever say to a patient, well, you've got a coping problem. I mean, that's a terrible way of destroying the therapeutic alliance. And you never want to be saying that to people. But as a way of thinking about this illness, then it's a robust construct. And it provides the basis for some therapy. What chronic pain patients want more than anything is to be taken care of. Right? And we all want this. We're physicians, but we're humans too. We get bad news, we get sick, and our natural human instinct is to want for someone to look after us. And that's why chronic pain patients come to doctors, because they want someone to take care of them. Mostly what happens is that most doctors interpret that, quite rightly in the first instance, as being a request to solve the problem. And when the problem cannot be solved, they lose interest. Or they do things that are still within the curative paradigm, which keeps the patient coming back, but you're spinning your wheels and no progress is being made. Here's, what do we call him? Bob? Bob's in this pinball machine of, go to massage, go to physio, go to chiro, go to the emerge, have an x-ray, have an MRI, ding, 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 ding. There's all this pinball going on with poor old Bob in the middle of it. And meanwhile, he just hurts like hell. He does what he's told, and he's not making any progress. So what do you do? I mean, we're here to give practical tips. Well, here's the first take-home point. Somebody hurts more or for longer than you would reasonably expect, given what you know about them, then the painful body part is probably not the problem. Right? Somebody's back pain, if they've got a normal neurological examination, it's probably their back pain is probably not due to their back. It may not be. It may be aggravated by poor condition in their paraspinal muscles, but we're not talking about a back problem here. We're talking about a human being who hurts, the manifestation of which is in his back. Take home point number 2 is that somebody needs to own the pain problem. Now, I didn't say fix the pain problem, but what they really need to do, what somebody needs to do, is to own it. Bob needs to know who's in charge of the back pain. Somebody has to steer the ship, because if everybody steers the ship, everybody's going to throw their 2 cents worth into this pain problem and send him back to the pinball machine. Now, how do you own the pain problem if you can't fix the pain problem? Well, let's take a little break. We've been going for 20 minutes. Let's have a little stretch. And I want you to listen to something. And what I want you to do is listen carefully to what I'm about to play for you, and just listen to the end.
The pain is definitely getting worse. Definitely. It's more severe now, and it's there all the time. And now it's even spreading. I get these shooting attacks up between my shoulder blades, all the way up to my neck. Sometimes it goes down into my arms, all the way to the tips of my fingers. And now I'm even getting these severe cramps where I can't even hold things properly. The burning, Jesus, the burning. It's like somebody's got a flamethrower going and running it up and down my spine. My legs, Jesus. I get this severe cramping, even getting up to do something simple, like going back and forth to the washroom, is just brutal. I used to get a couple of hours relief with those pills you gave me, but now they're not even doing anything. Well, maybe taking the edge off a little bit. I had to get my wife to shovel the driveway last week. On Tuesday night, I couldn't even get up the stairs to go to bed. I just sat there on the couch all night watching TV. Is it going to be like this forever? I mean, there's got to be something you can do. If it carries up like this rate, at this rate, I'm going to be in a wheelchair. It goes on, and it's getting worse and worse and more intense and more intense. Everybody keeps on telling me I should be exercising, stretching, going for that little walk. But that's all total bullshit, because they have no clue how much it hurts. Nobody realizes just how bad this is. Honestly, if you could just feel the pain just for a little bit, 5 minutes, you'd actually understand where I'm coming from. You really would.
Okay, so I want you all to just explore your emotional response to hearing that story. What did hearing that account and being forced by me to listen to it to the end, how did that make you feel? Right? It's unfortunate that we can't have a show of hands, but you know, probably what most of you wanted to do was to run like hell away from this. You don't want to be having that conversation. You, as he was describing how things were spreading, you started by thinking, well, geez, well, maybe he's got multiple sclerosis, or maybe he's got a spinal cord lesion, or and you worked your theoretical deductive powers to the limit, and then you just gave up because you just couldn't deal with it anymore. Because you were trying to solve the problem, you were in doctor mode. And I don't blame you, I don't criticize you. But as we've observed, given that all we can do is fix things in the body, by and large, and a little bit in the mind, we are only able to address a small part of some pain problems, and some of them will just be unsolvable. Unsolvable. So think of this guy. This is a plague doctor from, you know, medieval times. These guys got paid. You know, somebody paid them to come to their house with their little bird's beak and their rose petals. That's interesting. I mean, in therapeutic terms, what do they have to offer? Nothing. The physician of the tuberculosis sanatorium of the 18th century, some of the most highly regarded physicians in our medical history, people have written books. Those people have written books and we still read them. We still pay tribute to their beautiful descriptions of physical signs. But what do they achieve for the patients? Bugger all. I mean, they had no drugs, they had no surgery, they had no anesthesia, nothing. And yet somehow these guys had value. People wanted them to come. Why do we have an organization whose business it is to make sure that they sit with someone who's dying so they don't die alone? Why is that of value? Well, this is my plea to start treating chronic pain patients like that, in the sense that we have an incurable illness, but we have plenty that we can do as carers to support them through their journey. So when you hear a story like that, all you have to do is listen to it. That's all you have to do, but you have to really listen. Listening to tough stories is inherently therapeutic. Everybody feels better when they have a big, bad problem and they tell somebody else about it, particularly if that person is a person in authority, a physician or a nurse, or somebody who ostensibly could help them. Non-judgmental, take your time, I'm here. What people fear is that if they listen to pain too much, they're going to get dragooned into doing something they don't want to do. I hear this time and time again. Well, if I take the history, if I listen, well, then I'm obliged to do something. Well, what you may be obliged to do is something as simple as, well, yes, you know, that's a terrible story, and it really bothers me that you're suffering like this. And we're going to do what we can to try and find a way through this, but at the end of it, I may not be able to. And you and I together are going to have to live with that. That may be all it requires. It may not require you to reach for the dreaded opiate prescription pad, which is something that nobody wants to do. If you don't do this, if you don't develop a therapeutic alliance and just focus on listening with compassion and just moving the patient forward slowly, then you are going to feel compelled to do other stuff. You're going to feel compelled to order another MRI. You're going to feel compelled to try a different drug, even though you know it's not going to work. And he'll keep coming back because what he's seeking is kindness. And you'll keep doing things, and eventually the thing will just fizzle out and die. And it's unkind and it's unfair. I won't say it's unethical, but it's certainly not good medicine. Now, listening to tough stories is hard. You know, and I'm an anesthetist, right? I just talk to people and they don't talk back to me because I've intubated them. So I had to learn this. I had to learn this when I became a pain doctor. But it's a lesson that our forefathers in medicine knew very, very well. The real experts at this, they tell me, or they told me when I was a lad, that the thing to do is to really engage with the story in the room and then promptly forget about it. As soon as you leave the room, as soon as the patient leaves the room, forget the story. And you can do that. I teach fellows how to do that. And that means that you can be absorbed in the moment and you can give the patient what they need, which is you, and not carry it home in the evening. Okay. Diagnostic tests never improve a chronic pain problem. There is no diagnostic test that you can do in someone with chronic pain that will make them better. You can do this, the dreaded MRI, and everybody who has an MRI picks up their report and reads it. And if you're a member of the lay public, you look at that and you think, my spine is shot. I'm going to be in a wheelchair. This is an abuse of an excellent technology that serves no purpose. An MRI is almost never indicated in back pain, almost never. And here's some research that shows that if you image people with low back pain, their quality of life or their likelihood of improving actually gets worse. So if you look at the green box picks out most of the curves that favor no imaging. They actually make people worse by doing an MRI on their low back. So stop doing MRIs on people with low back pain. They're going to beg for them, and maybe you can only resist for so long. I mean, you're only human. Eventually, they just grind you down, and I understand that. But it's not a good test. Drugs will give you 30% if you're lucky. Anything else is a bonus. Now, I'm not that interested in drugs, to be honest. I'm not that interested in analgesic drugs for chronic pain because they're not that effective, but they are of some use. And I think if you go into them with the idea that they may just do something, but they're not going to be a panacea, then you've got something to work with. Remember that even drugs that you think are benign, like gabapentin, can be sold and abused on the street. Remember that you can have a bad side effect from any drug. And remember that there is very little research to guide the multiplicity of drugs that are applied at the same time. A benzodiazepine plus an anti-neuropathic agent plus an opiate plus a muscle relaxer. You are completely beyond the literature when you do that to a patient because we just don't know what the long-term and short-term, indeed, side effects of those things are. So this is pirated from Dr. Brisebois last week. And I put this up not to talk about these particular drugs, but only to say that there are pathways for these things. And if you're going to use drugs, then following them may not be such a bad idea. Encourage these things. So you're listening to Bob. You're really listening to him. You're saying, you know, there may not be a way out of this, but come back and keep telling me about it. Let me share that story with you. You're not a crazy person. This is real. And encourage these things. These things are all proven to be good for a patient. I mean, they're good for everyone. But of the things you can do in chronic pain, these things are the best things. Putting someone with a chronic pain problem temporarily off work is sort of hazardous. I understand that there's a real pressure to do that when somebody comes in and says, oh, I just need a couple of days. I just need a couple of days. And I don't criticize you for doing it, but just know that if you do that, you will probably prolong their illness and ultimately make it worse. Discourage these things. There is no evidence of benefit and lots of evidence of harm for doing these things. I would discourage you from sending people to physical therapy without specifying what you want. If you send someone to a physical therapist who you know and say, I need this guy to have an exercise program, well, that's wonderful. But if you just write back pain on a prescription pad and send it to them, what they will get is passive physical therapy. Things that will make them feel better for 20 minutes after they leave the office. And we can talk about the value of 20 minutes of pain relief in the context of a 20-year illness, if you like, but it's not the best thing. I would not send people for fluoroscopically guided steroid injections. There's no benefit. It's a cottage industry that has grown up and people do very well out of it, but the net benefit in terms of changing the course of the illness for the patient is zero. And I say that as an anesthetist. That's why I signed up for chronic pain. I don't do that stuff anymore because it's useless. And you are the first line of defense when people come to you and say, well, I saw this thing on the internet, you know, I saw this potion or this lotion. And you should be the first line of defense against that. I'm going to skip over this in the interest of time. Sometimes it's okay to use an opiate. Everyone's very unhappy about opiates, and sometimes it's okay to use an opiate. The literature says they are terrible drugs for chronic pain. There are now robust randomized trials to show that they are no better than alternative treatments for many kinds of chronic pain. But you might find people who have gotten their cirrhosis because they use drugs. You might find people who, as a legacy from the 80s and 90s, come into your general practice office on large doses of opiates. There's a measured response that is required in these cases to make sure that you don't just throw the baby out with the bathwater. When I say it's not the end of the story, don't assume that because you've given someone an opiate, you've solved the problem. Because after all, if the problem is contained on one of the three legs of the stool that you haven't addressed, it's not going to do anything. Dr. Brisebois came up with a wonderful phrase that I'm going to use now, which is drugs work on receptors. And all those receptors are connected to leg 3 of the stool, the one of the body. This is sort of my view of what we're trying to do with opiates. So nobody wants to create, I shouldn't use the word addict. I should have used opiate use disorder, but I couldn't fit it on the slide. Nobody wants to create a problem with drugs. Nobody wants to take a person who has a drug use problem and make it worse and feed it. So what we're trying to do is we're trying to go down the green line here on the left of the slide. We want to take a pain patient, we want to give them prescribed opiates, we want to see them do well. What we're terrified of is the orange line. And these are real events. I mean, people die of opiate misuse every day. So if you're going to do this, then phone a friend would be my advice, particularly if the dose gets above 30 or 40 milligrams of opiate equivalent a day. Phone somebody and get some help. Or if you're not going to do that, then stick rigidly to some of the protocols and plans that have been devised in your interest. Think about why you're going to give someone an opiate. Is it to just make their life better? I just want a bit less pain. That's not good enough. Someone says, if Bob says to you, geez, if I could have just something to help me get through 9 holes of golf with my buddies, and then that would be great. Well, that's fine. I mean, I can put flesh around those bones. How long are we going to try this for? A week? A month? What are we going to do if it doesn't work? Well, we're going to stop the drug, obviously, but how are we going to do that? Prepare for all that stuff before you go in. And again, if you don't know, ask. It's far better to have a plan than just for the patient to say, these drugs aren't working. Okay, here, let's start opiates, and then let's see what happens. What are you going to give me in return? Yes, that's right. I'm going to give you some opiate. What are you going to give me in return? Maybe an extra 20 minutes of physical activity, maybe a trip to the swimming pool once a week. I don't know. You need to know how to diagnose opiate use disorder, and it's not hard. I mean, you don't need an addiction medicine specialist to decide if someone's misusing their opiates. Here's a checklist from the BC Centre for Substance Use. I mean, these questions are pretty self-explanatory. We should put this up on the web. I forgot about that. Here's an even easier version of the same document in plain language. If you tick 2, 3, 4, 5, or 6 of these boxes, then you have a problem. Now, I'm not saying that someone who has opiate use disorder doesn't need compassionate management, but unless you have some expertise in this area, you probably should phone a friend. If you're going to prescribe opiates, use the opiate manager if you're in Canada. If you use this document, it's on the McMaster University website. It's an offshoot of the National Guideline on Opiate Use. If you use this document, then you are bomb-proof when somebody comes asking about what you're doing. If you don't use this document, you might still be bomb-proof, but you're going to have to work a lot harder. And I would stick to these 2 drugs. Honestly, I would stick to Dilaudid if you're going to use an opiate in the cirrhosis population. I would stick to Dilaudid. And if there's any innuendo of substance abuse, I would use Suboxone. And Suboxone is a tricky drug. You need to learn how to use it. CME is readily available. We can point you to those resources. But those would be my recommendations. I'm sorry that I'm already 38 minutes in, but I'm almost done. It's good to know who to call for help, but know what kind of help to expect. The pain specialist community is a bit divided. It's a bit fragmented. It's a bit middle-aged. There isn't the kind of service that we'd like to provide. We're very sensitive to this. the dump and run. You know, we can't manage everyone with chronic pain, much as we'd like to. And if your intention in phoning a specialist is just to get rid of the patient, then you're going to get a different response than if you seek some sort of collaborative solution that we can both work at. And again, as Dr. Brisebois so wisely said last week, the thing to do is pick up the phone. Know someone in your community, know a pain specialist who'll take phone calls and say, look, I've got this guy, this is what I think, what do you think? And you'll usually get a workable and usable response that will save everybody a lot of time. Here are some good examples, and I'm going to whip through these in the next 2 minutes. Loss of function because of pain. Someone who's got no insight into psychological factors. If they say, well, yeah, all that mind-body stuff, that's the other losers in your waiting room. I've got real pain. That's the kind of person we need to see in the pain clinic, if only to start disabusing them of those notions. Someone who's, on the other hand, really keen to try a rehabilitative approach. We like those people. Someone who you just cannot get to exercise. You've told them, well, maybe we'll have more luck. We strut about in white coats and scrubs, and we look a bit more impressive. Maybe that might make some difference. If you've got questions about opiate appropriateness, again, better managed over the phone, but certainly you can send a patient to us for that. You're not sure if it's structural or functional, or you think a patient might have RSD or something. And if you need someone just to reinforce what they're saying. If you failed first or second line drugs. In Alberta, if you want access to time-based fee codes, we should talk about that in the Q&A if you don't know what I'm alluding to. And if you just can't generate the therapeutic alliance, you just need help. I get phone calls from people in small towns saying, this guy scares the shit out of me. And there's nowhere else for him to go. And I can't deal with this, I'm frightened of this patient. Well, I'll send him to, that's a good person to send to the clinic. Or you've got no idea what to do next. These are just some examples of when you might invoke our service. So I'm done. These are the things that I said I would cover. Some pathophysiology of chronic pain, some common approaches, some tips, some opiates, some questions. And so now let the fun begin. Thank you very much.
Awesome, Saifee. Thank you. That was a super practical talk. So I just want to introduce Amanda quickly, and then we'll start questions. So Dr. Brisebois, we met last week. Thank you, Amanda, turning on your video. Just a short bio then. She's both an internist and attending physician at the Grey Nuns Hospital, and she's done extra competency in palliative care. So she's a palliative care specialist as well. And she's worked a lot with cirrhosis patients in the PPRISM clinic, which is a non-cancer palliative care outpatient clinic that was running and located in the Edmonton clinic. And she's got adjunct appointments both in the Division of Palliative Care and the Division of Internal Medicine. So welcome, Amanda, as well.
Thank you.
Let's have a peek at the questions. So first off, Saifee, I think that was such a practical approach, like I said, with the non-pharmacological management built in, and really that therapeutic alliance piece instead of just going right to drugs, but which is so important to
just goes to, were you guys even listening to me? Were you paying attention?
Us, Saifee.
yeah, you I know. Okay, so is dilaudid safe in hepatic, and is that hepatic encephalopathy?
Yeah, exactly.
With LC, is that liver cirrhosis?
Yeah, liver cirrhosis with
yeah.
H.
Well, it's the dose, right? I mean, you've got to use, if you're going to use an opiate in that situation, your three options in my view are fentanyl, hydromorphone, and buprenorphine, right? So what are you going to do? And of course, it's about the dose. So if you're going to do the Amanda Brisebois approach and give them 0.001 milligrams, then it's safe in. You could give that to a neonate, no problem. It's about the dose. So start low, go slow. Yeah, it's a safe drug.
Amanda?
I just absolutely love hearing you talk, Saifee. So thank you so much. The principles that you talk about, I learned the hard way a lot of it when I had my clinic, because initially I had thought that, oh, I'll give a medication and they'll be better, and they'd seem better for one visit, and then there weren't. So I do think we we get caught into doing that right away. But yeah, these small doses, you can get hydromorphone in liquid, but it's much harder in the community now because they have to compound it. So the patients have to know either how to draw it up into liquid compound, or they have to be able to pay for the syringes pre-filled, which are about $1 each.
Or you could just give them a milligram, Amanda.
Yeah, or you could give them a milligram. But if you do that, or half, you could cut it in half. What I said last week, I don't know if you were there, but you could cut it in half and just give it before bed. And if they were really sleepy, whatever, it doesn't matter. So you can test it that way. So
Start low.
start low, see how they go. And if you give one and they don't, if it's too much, then you can look into those other options that are more complicated. So I think that's totally fair. It's much easier to give the tablet.
Can you use Suboxone for chronic pain? Yes, you can. Absolutely. Yeah.
Okay.
Yes.
And then the other question.
Now, I wouldn't use. I mean, I'm talking about the high risk patient. Like, I don't think that it could be your kind of straight out the gate drug for someone who is medically or psychosocially non-complex. Yeah, it would raise a few eyebrows. It's the thing about being on Suboxone is it raises a few eyebrows when they hit the emergency room or when they go somewhere. People are, oh, Suboxone. So it's to be used judiciously. But yes, absolutely. Take one of those courses. There's only one way you can screw up Suboxone, but it's a big way. And you can make the patient very sick temporarily, but you can make them very sick if you don't get the sequencing right. So don't just whim it. Take a course. What are your tips for deprescribing and persuading the patient to agree with you? Okay, my favorite topic. So the first thing is you have to have a really solid therapeutic alliance. You can't wean somebody who doesn't trust you. If they don't trust you as your physician, they're going to say, you're being told to do this by the government, they mean the college. You're just terrified of they'll start with all this stuff. But if they really trust you, and if you say to them, look, here's what I know about opiates. They are bad for you. They are rotting you from the inside out. They are sucking the calcium out of your bones. And they are the reason that you have erectile dysfunction. And they are the reason that you can't remember where you put your car keys. Right? Some of those things will get better. But here's the kicker. What the evidence says that if you take the opiates away, your pain will get better. So those are the pearls that you dangle before them. And then you say, look, how fast do you want to go? Use really, really small increments. A milligram here, milligram there, milligram a week. I mean, do some creative math. Use small dose pills. But once you get the patient to buy in, once you get the patient to trust you, and once you tell them what the benefits are, then you have a shot.
Can I add to that too? Because that's excellent advice. I have a patient that I saw probably 2 years after I'd done my palliative training, and he was on multiple pain meds, clearly massive doses. So I went in thinking I was so smart. This was an inpatient, and I started deprescribing, and I spent hours with them explaining what I was doing, and I felt so smart. Well, I actually got a complaint from this patient's family saying that I didn't know what I was doing. And I made that mistake, Saifee. Like, I was somebody who didn't have that therapeutic alliance with them. I should have called the family doctor and had that discussion because they had a very tight therapeutic alliance. So it's easy to go in thinking, oh yeah, I'm going to fix this. But if you don't have that relationship, so I really appreciate that opinion. And the only other thing that I do is before I start them, I counsel them with that whole total pain thing and explain that they may get the medications weaned off if they don't work. Prepare them ahead of time. I don't know what you think about that, Saifee. Do you do that?
Well, people in my world have pretty short memories, you know.
Truth. Yes, that's very true.
They they remember selectively. So if you say, well, you know, I did tell you that we're going to wean these away. I mean, it's even Stevens whether they remember or not. And to be honest, I'm rarely in the position where I'm starting opioids. I'm often the cleanup guy, you know. And so I never have to have a conversation about what we did when we started them because I rarely start opiates now, rarely in the ambulatory patient. Really. Oh, we missed a question at the beginning there, Panita.
I know you're doing such a good job moderating, so I'm just gonna.
Oh, sorry. Sure.
That's okay. You're doing great.
Over to you. Moderate away.
Okay, so a dementia patient who's pain focused, is there any tips there where you've got a patient who's anxious and fearful, but they lack executive function to work through that mental aspect of pain?
I think you play the hand that you're dealt, right? So you can mobilize them. I think even with a certain amount of dementia, you can develop a therapeutic alliance. But you've got to play the hand that you're dealt. You have to whittle away the most dangerous aspects of their care. I mean, if they're on things that are potentiating their cognitive impairment, I mean, I'm no geriatrician, but that would seem obvious. But you play the hand that you're dealt. I mean, if all you can do is take them for a walk, not you, but get them to go for a walk every day. If all you can do is just say, well, I'm sorry, I can't fix this, then that's all you can do.
Yeah. Okay. And then the best pain control approach, so these difficult patients, an over 80 population with osteoporosis and compression fractures.
Well, people with osteoporosis have sarcopenia. They have, in addition to their age-related decline in muscle mass, in bone mass, they have an age-related decrease in muscle mass. And most of the time, people with back pain and osteoporosis, elderly people with back pain and osteoporosis do indeed have vertebral compression fractures that are causing some of the pain. But inevitably, when I examine these people, their muscles are like concrete and they wince as soon as I touch them. And it doesn't take much work to improve muscle quality. And that has a tremendously therapeutic effect. So the answer to your question is to get them mobilized to the point where they're actually, there's some very elegant evidence about the value of resistance training in elderly people, even elderly people with quite profound cognitive impairment. And so go for the muscles would be my summary answer to that question. And I would not send them for vertebroplasty, honestly. That's just my opinion, but vertebroplasty is where they squirt cement percutaneously into a collapsed vertebra and sort of puff it up like a tire. You know, they often need sedation. They often need a hospital inpatient stay. I mean, the radiologists get mad when they hear me say that, but honestly, I'm not sure that it does everything that it's cracked up to do. It's a physical solution, right? It's a technical solution. People love those, but I wouldn't do that.
Okay, and then the other question on there about Suboxone and opioid use disorder, and they develop acute pain, like a fracture of bone.
That's a great question. I'm really glad somebody asked me that. So Suboxone ostensibly makes it harder for standard mu receptors opiates or standard opiates to bond to the mu receptor because it's covered with Suboxone. And we used to think, well, you've got to get rid of the Suboxone to do that. But what you should do is continue the Suboxone and then just give them a supranormal dose of opiate on top of that for the fracture. And the drug, again, is Dilaudid. Dilaudid is the best drug. So if you've got a Suboxone patient who has a legitimate need for supplemental analgesia, you can either just up the Suboxone, but if you want to use something else, something a bit more short-acting and a bit more potent, then high-dose Dilaudid is the way to go. And I recognize that if someone's on Suboxone for opiate use disorder, then the prospect of using a bit of high-dose opiate is challenging, you know. But if the alternative is just to say, well, yeah, you've got opiate use disorder, you know, piss off and suffer, well, then, I mean, that's not really very good, is it? Not that I'm suggesting that you would say that, but unfortunately, there are situations, we specialize in the university at situations where everything is contraindicated. Well, you've got to do something.
Yeah. Okay. Opioid use heading into transplant. Yeah, that's a
well, transplant surgeons hate opiates with a passion, right? And I get these referrals all the time. Would you please see this guy in whom we're considering transplantation? Can you get him off opiates? I said, what am I, a magician? I mean, what do you? So I say to the patient, I said, there is a strong prejudice against you. You are going to be lower down the transplant list if you're on opiates. No matter what they tell you, they're going to discriminate against you. So If you want me to help you get off your opiates so we can shine you up a bit and get you up the list, I'm happy to do that for you. But I don't have a non-opiate alternative to what they, particularly if they're on high dose opiates, particularly. And so, interestingly, that's not true with intestinal transplants. They'll tolerate people with intestinal transplants on opiates. So my opinion doesn't matter really. What matters is the opinion of someone who's handing out the livers, right? But deprescribing is never a bad idea. Deprescribing is always a good idea. And if you have someone who's heading down that pathway, then early on, I would advocate for the slow, trust-based deprescribing, because it's good for their health anyway. And if it moves them up the transplant list, so much the better.
Okay. And then is it appropriate to give these small doses of opioid to make, I guess at times, to make them willing to get out of the bed for physio?
So long as you get what you're paying for, right? So long as you get that. If you can be sure that that's what that is the result, then great. I mean, you've done a wonderful thing. But if it just becomes part of the background and it just becomes part of their regular regime, and they're still not getting out of bed, and they say, well, actually, I need 2 of these now. Again, going back to my slide, know what you want, know how long you're going to give it a try for. What are you going to do if it doesn't work? In many ways, we out of time?
No, you're good. Yeah.
In many ways, the problem with opiates is not that people start them, it's that they don't stop them. It's, if I could solve one of those problems, it would be that.
Okay, that's great, Saifee. And then Amanda, I really wanted to just ask you to maybe give us in the last couple of minutes your experience in the P-Prism clinic, because you managed a lot of our cirrhosis patients there. Do you have any additional tips to what Saifee's?
Well, I think a lot of it really is that, and what I talked about last week, that the immediate answer and what the patients often come in for is a prescription. And I really learned quickly that that's just not the right thing to start with. And it's all those conversations and finding out how the pain's affecting their lives and what it means to them and what they think it's from and how it's changed and all of those things. And then sending them home with the non-pharmacological stuff. And patients don't really love it. But the reality is they do better like that. And I've had much better success working that way. So I think medications, as Saifee said, there is a place for them, but I personally feel patients do better without it. And in the cirrhosis population, they have chronic pain. They have ascites, it goes up and down. They have pretty significant back pain. They have abdominal pain. Those are the main areas of pain, sometimes some joint pain too as well. But you can't get rid of the inciting events because it's very difficult to control those things once they have decompensated cirrhosis. So they really fit into these categories of chronic pain. And then they have a liver that doesn't work. So you have all the pharmacologic issues with medications. I totally agree with Saifee, obviously, with these medication selections. I think if you have just a few things in your toolbox, you'll get better and you'll get very familiar with using those few things in your toolbox rather than playing around with multiples thinking that, oh, if hydromorphone doesn't work, morphine will. I've just really had, in my experience, it doesn't, by switching around to a bunch of different things. So I really like that approach, and I'm glad that that's what's going on the website. That's great. And I just put another plug in for the website, Panita, that's going to come up with some of these recommendations that Saifee has so graciously been involved with as well, because I think a lot of that will make it a little bit simpler and give some of these tools for assessing pain, etc.
Yeah. And bottom line, it's not a quick discussion, right? It takes time.
No, it takes a long time, and you see the patient. And so what I would suggest to primary care practitioners too is, these are discussions that maybe you book separately instead of trying to manage the actual illness part of it, which often they come in and they want to get a little checkup and get examined and everything. Well, maybe they come back in to just specifically talk about pain rather than feeling that you're rushed, because it is a very long conversation.
There's a participant saying that they didn't see the slides. Could that be true?
I saw them.
Great info, but the slides were not showing up, just the FaceTime.
Oh, yeah, I think they were showing, but you will get the recording. So not sure.
Saw them only at the beginning. Okay, well,
I wonder
sorry.
maybe I wonder if everyone's like that, because you'd think more people would have mentioned something. It might just be that one person.
Maybe it's just that one
Yeah.
one person.
Yeah. I saw them, they were great, so I don't know.
I spent
I'm
a lot of time on
happy.
them. I spent a
Yeah,
lot of
I
time.
know.
So I guess, yeah, we are at the hour.
Oh yeah, Dr. Dringa to our rescue. Thank you, sir. Or sorry, thank you, Doctor. They were able to see the slides.
Okay, perfect. So thank you, Saifee. Thank you, Amanda. And we're wrapping up the 6th cirrhosis webinar series. And thank you, everybody, for showing up. Thank you, PLP, for helping us to arrange this. And we'll be doing a special launch of the website on the 15th. So everybody will get an invitation to that. And we hope to see you there. And enjoy the rest of your evenings. So wonderful.
Thanks, everybody. Thanks, Saifee. I always love
No,
hearing
thank you.
talk.
No, I had a great time.
Super great, Saifee.
All the best. Yeah. Bye-bye.
Bye.
Bye.